Today, I would like to speak about clinical relevance of the pieces of information flying out there on concussion. Again, I have talked about concussion in the past. It is also called mild traumatic brain injury. That means that it is an injury to the brain with expected mild prognosis. Concussion happens when the brain itself is perturbed, where impact to the skull, either directly or indirectly. By indirectly, I mean loud, high frequency loud sound, such as an explosion, can trigger waves that will perturb the brain, just as a direct impact would do to your brain. So that's what I mean by indirect impact to the brain. So now let's talk about the application of scientific literatures and how we can determine appropriate clinical relevance. Before we do that, we must be able to stratify the uh, levels of application. I want you to think that you are seeing a patient, and when you see a patient, you're going to take history. There's going to be a temporal orientation profile. After that, you will do some diagnostics in order to confirm what might be wrong. Then you go to treatment. Then after treatment, you as a sports medicine doctor, you just don't want to heal your patient. You want to return them back to play. So there's a process involved in that. So we have stages that have been studied. So I'm going to quickly touch on those. And when you do apply to those stages, another way you should be able to determine clinical relevance is when you are returning the patient back to the field of play, is what type of play is this going to be? What level of activity? So again, I want us to quickly stratify the patient population in the realm of sports medicine into elite, the high intensity requirement patient population, versus people that have mild exposure to this particular type of sports, such as in my own opinion, I would say high school. I know there are high school students that are being pushed to the limit to be able to achieve their elite status. So those, to me, in my mind, I would also consider them as elite. But again, we have general high school sports. And we also have weekend warriors, as well as organizations So that is also very important. We have like just maybe YMCA, you know, Boy Scout, Girls Guide, organizing sports. So we must be able to say, okay, this particular level is not requiring uh, the patients to be under immense pressure to perform. And that may determine prognosis. That may determine recommendation for return to play or level of testing prior to return to play. Okay, let's start with temporal orientation profile. So far, I would let you know that nothing has really changed with regards to the fact that all the patients that come to you when it comes to concussion, they believe that they have head injury or they have had something wrong with the head. Doctor, I'm not right. But we have evidence that came out that ADHD prones a patient to concussion. Now that's new in terms of the fact that it has been established via empirical evidence now. So what does that mean to you as a provider? Number one, I would say that if a patient has been diagnosed with ADHD, the coach should be aware. Throwing injuries are bound to occur when somebody is not focused, because ADHD itself already affects focus. Um, if the patient is well medicated, you may have to discuss with the Olympic Committee about acceptance, about waivers. If the patient is stable, there may be a gradual process involved, but the most important thing is that there has to be a consensus. There has to be a level of agreement with the coach, with the parents, because this is not a matter of discrimination. Discrimination is a matter of making sure that we are aware that being prone to concussion means that we can prevent a situation. So if in cases of prevention, we have to avoid exposing high risk individuals such as high school athletes to some sports, because as they advance, need for speed, need for more concentration may affect them. So those are the areas where this part of level of evidence, this part of clinical evidence, empirical evidence may apply. So this is more or less like the psychosocial aspect which means that you call a meeting, you evaluate, you determine, what should be done. And this is very important in prevention of acute concussion. This may be relevant in high school, and I want, based on my experience, if you talk to parents can say, well, I don't feel too strong about this sport. The doctor is recommending, the patient may have other conditions as well, which may be aggravated by concussion. So that's very important. Now let's talk about what's available for diagnostics, physical exam. I would combine diagnostic and physical exam in that realm. So we have a lot that have come up in that regard. So let's speak. One article came out, and in fact, I love all the articles that have come out so far when it comes to diagnostics. And this diagnostic can help us to do what? Diagnose concussion itself and determine prognosis. I will focus on the latter. Articles kept rolling in on King-Devick test. King-Devick test. And it's a test that could be easily taught to a coach or could be performed on the sideline by the sports medicine physician. If an athletic trainer is present, they should be able to perform it, but a physical therapist, which we usually don't have that luxury. So I believe that an athletic trainer can learn King-Devick testing, which shows eye movement abnormality immediately after a concussion. Okay, now we can use that to diagnose concussion on sideline, but we can also use it to determine prognosis, because according to literature, poor recovery is associated with that. So again, I will discuss what I mean by poor recovery. We have something called post-concussion syndrome. People that are symptomatic after 1 month from the day of their concussion incident. We can use King-Devick simple test to determine prognosis, and this is how I will use it. What is the clinical relevance? From that day, you just had concussion and you don't look right, just like the USA boxing does. If you get knocked out, you're out for at least a month. If you are positive, if you have King-Devick, if the King-Devick test is positive, you should be out for a month at least, because that is about how long it will take you to recover, because we expect mild concussion to recover, to people suffering from mild concussion to recover after about a week or so. More than 3 weeks is becoming a problem. But now I want us to consider establishing 1 month. So that's what I would do to be able to protect my patient. I'll give them a kind of, I will assume, protracted recovery time. Therefore, I will not start return to play early for them. We also have, similarly to King-Devick, which is simpler, we have the impact testing. That's the impulse control assessment test. It's a computerized test. It's more rigorous than the simple King-Devick. But again, it's going to determine those patients who are likely to have a protracted recovery. again, I'll give them probably at least 1 month. But what's the difference between simple test and complicated test? Most of the time, you will need a neuropsychologist to spearhead impact testing, and that is additional cost. So, but again, it's more accurate. So, in that regard, I recommend that for elite athletes, people that we want to make sure that there is no problem, and those that we want to provide recommendations for, because again, when a neuropsychologist performs impact testing, there is going to be a follow-up visit where recommendations are made. So clinical relevance, I would say, for elite athletes, and there should not be problem cost-wise, because again, you need higher level of care in that regard. The another test that has come out that's very, very important in actually determining prognosis of concussion is the amplitude adjustment ratio. I believe it's amplitude adjustment ratio. It's a test to determine the amplitude change in a concussed patient. The amplitude of the pupil, normally you are supposed to accommodate properly. Apparently, during concussion, there is a problem with that accommodation, and there's a way to measure it. Now, I think that test should be done by an optometrist. So you need a simple referral to an optometrist. If you are not a sideline physician, and maybe you check your patient and you know how to do the King David, or maybe you have somebody that could do it in your gym, and it was negative, maybe it's too late to pick it up. A simple referral for an eye exam by the optometrist, whereby you specify that this is what I'm looking for. Because again, not every optometrist is game with concussion. So this is what I'm looking for, please assess and recommend. It's actually good to have an optometrist on board, because if you say evaluate and treat on your referral, this is what's going to happen. They give you the report that, okay, there is a poor amplitude, pupil amplitude in reacting to near signal confrontation, near object confrontation. You use that for your prognosis, but at the same time, the optometrist can also recommend ocular therapy, vestibular ocular therapy, which means that you, in one sense, you predict protracted recovery, so you take action right away. Talking to the coach, recommending, limited play, recommending a protected return time, whereas the patient undergoes therapy. So that will provide a better prognosis for the patient. So pretty much we have discussed a lot about diagnosis. Let me bring one more in. Another test that could affect prognosis. Most providers work with physical therapists hand in hand. And if you have a small gym close to you, this is a test that can easily be performed. It's the exercise treadmill test. If within the first 10 minutes, a patient who has suffered concussion starts to experience symptoms such as autonomic symptoms, and one of the common symptoms is headache. If headache starts to happen within the first 10 minutes, empirically, they've shown that this is a sign of protracted recovery. So in my case, like I said, 1 month no play. I will recommend that based on empirical evidence. Again, all these are subject to whether the patient is recovering fast enough, is getting treated early, and the nature of the sport the patient will be returning to. There is also the vestibular testing, whereby they do single leg hop and test the patient's proprioception, but it's more of like a vestibular testing. Simple test that you could discuss the result with your physical therapist and say, well, is this okay or not? Again, that can determine protracted recovery. So we have more tools in our armamentarium to be able to prevent a patient suffering as a result of early, premature return to play in terms of concussion. So I'm going to skip that. We're going to go to treatment. Treatment, well, what I know that a lot of experts will do is check vitamin D level. Mostly they start vitamin D right away. They will check vitamin B12 level. Mostly they will start vitamin, because again, you can boost vitamin B12 level way above the recommended minimum. Then they will start fish oil, because those have been shown to help brain recovery. Now, riboflavin, vitamin B2 has now been shown to be helpful in faster recovery, so I will consider that. That's it on the latest for treatment. Like I said, there's a lot of treatment for concussion, and finally we have the 5-step return to play. The 5 steps process, I think that should be adhered to, in that it's becoming more clarified as a form of return to play process. Therefore, I believe that we have to understand what return to play means for each athlete. Once we do, we tailor his or her treatment profile accordingly. Another way to know if maybe there's a problem with return to play especially in concussion, or if you want to know that concussion is still present, or maybe there's something that you missed. Again, the reason why I'm putting this at the last end of the spectrum is because of cost and higher level of care. Now, we're going to go to the number one specialist that we sports medicine providers consult with. So you might have to send the patient to a neurologist for P300 evoked response potential, which is they're going to throw an oddball in a patient's field of view, and you're supposed to evoke a response potential within 300 seconds. Now, if there is abnormality with that, I believe that they will discuss with you, with the patient, about possible